Hello guys, Dr. Shubham here, and today I have come up with a very important topic, that is obesity. Almost two-thirds of the population is disturbed with this disease. Why I am calling it a disease, you will get to know, because it is a multi-system disorder. We do not consider it. We consider it as just an obesity, and we do not take the proper preventions to control it. We do not take the proper treatment. We do not know when our drugs are indicated. We do not know when surgery is indicated. And so are the patients. They are coming to us taking many laxatives to reduce the weight and many other medications which are not at all allowed in obesity disorder. By and again I am saying it is a disorder because it is a multi system involvement. बहुत सारे system involve होते हैं, neurological, cardiovascular, GIT, renal, genitourinary, musculoskeletal. Even your fertility is based on this factors because it is basically a hormonal disturbances, basically the problem with leptins, ghrelin, and basically the problem with the appetizers and the satiety centers. So in whole we have to study this whole disease, the whole disorder. Okay, so we will first of all we'll just look at the definition, that what is the obesity, what are the tissues involved in it, what are the cells involved in it. Then we will see the etiology, and by and large I will cover the pathophysiology in between, and definitely the treatment at the end. So, let's see. First of all, let's see the definition. So, what is an obesity? Basically, the obesity is excess of adipose tissue mass. So, it will be a adipose tissue that will be collected. And what will happen? This adipose tissue consists of your macrophages and your adipocyte cells. So, your macrophages will increase in number. Okay, so when they will increase in number, they will get deposited, and our body will be in energy excess state, so it won't be converted, it won't be metabolized. So and we will see the process further. Okay, so we have to remember that obesity is excess of adipose tissue mass, and definitely I have told it is a modern epidemic. And body mass index more than 30 kg per meter square, we call it as obesity. And in the Asian population, as in Indians, more than 27.5 per meter square kg per meter square is an obesity. So, though a BMI more than 27.5 kg per meter square defines obesity in Asian population, I have again re-highlighted it. The reason being, we have to see it according to Indian standards. So, it is more than 27.5 kg per meter square, right? So, the next thing we will see is the classification. Very important. Most of us, we do not know the classification, right? And how do we how do we classify it? So the normal weight is 17, the normal weight, the BMI will be 17.5 to 22.9. Underweight is less than 17.5. Overweight is 23 to 27.4. Obesity, grade 1, grade 2, and grade 3. Grade 1 is 27.5 to 32.4, then 32.5 to 37.4, and then more than 37.5. Why I have this European is hidden is because we get confused. So I have kept it simple. I have kept only for the Asian population so that we do not get confused. Less than 17.5, it is underweight. More than 22.9, we say it is overweight or obesity or extreme obesity, and then we further classify it, right? Now, what are the controllers of appetite? What are the things that are increasing your appetite, and what are the things that are decreasing your appetite? First of all, we will see the central appetizer which increase or decrease the appetite. So the appetizers that increase the appetite are, you have your neuropeptide Y, you have a melanocortin hormone, melanocyte concentrating hormone, then you have a GOTI related peptide, then we have orexin and endocannabinoids. They will increase your appetite. And in contrast, your alpha melanocyte stimulating hormone, your cocaine and amphetamine related transcript, glucose like peptide, and serotonin, they will reduce the appetite. These are the central appetizers. And what are the peripheral appetizers? Your psychological factor, environmental factor, cultural factors, many hormones such as leptin and insulin, then glucose, ketones, CCK, ghrelin, they all the peripheral appetizers related to obesity. Now, there's a term known as adaptive thermogenesis. So we have two types of adipose tissue. We have a brown adipose tissue and we have a white adipose tissue. So our brown adipose tissue, it has a role in metabolizing the energy and preventing the obesity, right? It will stimulate the production of more, and it will stimulate the utilization of more and more energy by a leptin that is stimulated by sympathetic nervous system. Then we have a white adipose tissue that will store the energy, that will concentrate the energy at one position, and that is the reason for the obesity. Okay. Now, our adipose tissue, as I have already told, it consists of a lipid storing adipose cell and a stromal cells consisting of pre-adipocyte and macrophages. In obesity, these macrophages will increase in number. What is the most important transcription factor to be considered here? That is our PPAR gamma, right? Now, these adipocytes, they have many other cytokines, hormones, and the other factors inside it, like factor D, that is adepsin, leptin, adiponectin, resistin, TNF alpha, interleukin 6, free fatty acid, glycerol, aromatase, and RBP4 and angiotensinogen as well. So that is why we give ACE inhibitors, ARBs, in the patients who are obese rather than beta blockers. Reason being, they adipose have an angiotensinogen inside it, so we give angiotensinogen inhibitors, right? Now, what is the etiology? What are the I haven't covered all the causes, but very common causes which should be directly strike to our mind when the patient comes to the OPD. Twins, whether they are living in any how much different areas, the twins are going to have the obesity. Then the genetic factors are there. Then androgen deficiency in males, androgen excess in females, or ovarian failure, for that matter. Drugs I have discussed further also, but these are the common drugs: glucocorticoids, lithium, antipsychotics, antidepressants, environmental factors, nutritional excess, a lot of fast food, and a lot of imbalanced diet, to be more precise. Cultural factors: some consume a lot of ghee, some consume a lot of unsaturated fatty acids. Some cultures consume a lot of saturated fatty acids. Per se, North India and South India are typical examples. Diet composition: some have more of the carbohydrate content in their diet, some have more of the protein content in their diet. And physical activity: how much physical activity per day we are doing to keep ourselves fit. And most of the people don't know how much to be done. So I have discussed further. It is either 75 minutes of vigorous exercise or 130 minutes of moderate exercise per week. Okay, after that we have syndromes related to obesity. We know glucocorticoids, Cushing syndrome, hypothyroidism, raised TSH, insulinoma. So patient gains weight because of overeating. Why he is overeating? To avoid hypoglycemic episodes. Craniopharyngioma. Hormone levels in obesity, very important. You will start the medication, you will start the patient on phenetramine, or you will start the patient on toltrodine or any other orexins, but you also have to give vitamin D to the patient, because there is a vitamin D deficit in the patients of obesity. There is reduced GLP, there is reduced ghrelin, and there is increased leptin. How you will evaluate the patient? So we have divided it like the other histories, like the other diseases, it has to be treated like a disease. So you will take the history, you will do the physical examination, you will ask for the comorbid conditions, you will see the fitness level of the patient by looking at the BMI, arm circumference ratio, uh, waist hip ratio, and you will motivate the person for some lifestyle changes. Okay. Now, drug history: either he is on insulin, sulfonylurea, thiazolidinedione, steroids, antipsychotics, mood stabilizers, anti-epileptics, antidepressants. Family history of obesity should be taken very carefully. Then the measurements: you have to look at the BMI always. Then the skin fold thickness, densitometer, underwater weighing, CT scan, and MRI. Okay. In South Asian population, you also have to look at the waist circumference, Men more than 90 centimeter, we will tag it as obesity, and in women more than 80 centimeter, we will tag it as obesity. Now, assessment of body-related comorbid condition, you have to look for diabetes by looking at FBS, RBS, HbA1c, urine routine, urine ketones. You have to look at lipid profile to look at some atherosclerotic event taking place in the body, blood pressure to look for any hypertension, ECG for any coronary artery disease, and 2D echo for any structural heart disease. Assessment of the patient for the readiness to change. Now, how much patient is ready? One patient is coming to you that doctor, I will regularly do the exercises as you will motivate me. Other will say, I don't want to do exercise, I just want to pop up some medicines and I want to get fit. Some will say, doctor, I don't have time for medicines, I don't have time for the exercise, just do the surgery and remove my fat and that's it. So that is the category of the people. Some will come very motivated, but within a week or within a month they will lose their motivation and they will literally shout at you that, okay doctor, give me some medication, I want to lose weight, and I have some important family function. So your psychological counseling becomes a very important factor. So you have to motivate the patient, you have to see the psychiatric status, how stressful his regular life conditions are, how much time is available with him, and what is his goal. Some just want to reduce 2 to 3 kg, some want to reduce 20 kg, so it depends. Now, I was talking, I was from the first word of this lecture, I was saying it is a disease, it is a disorder. Why? Because you can see on this whole picture how many systems are included, from the neurological to the genitourinary to the psychological, every system is included. So, in neurological, the patient can develop stroke, myalgia parastatica, dementia, in cardiovascular, hypertension, coronary artery disease, ischemic heart disease, congestive heart failure, varicose vein, and pulmonary embolism, endocrine, type 2 diabetes mellitus, metabolic syndrome, dyslipidemia, PCOD. Then in respiratory, because of excess obesity, patient can develop sleep apnea, dyspnea, hypoventilation syndrome, Pickwickian syndrome, asthma. GIT, GERD can develop, reflux gastritis can occur, non-alcoholic fatty liver can occur, cholelithiasis, hernia. For that sake, colon cancer can also develop. Musculoskeletal patient can have high uric acid, gout, immobility, osteoarthritis, because all of the weight will be concentrated on the knees, low back pain, carpal tunnel syndrome. Psychological patient can go into depression, he can go into body image disturbances, social stigmatization can occur. Then integumentary, there can be a stria distensi, stasis pigmentation of legs, lymphedema, cellulitis, and in genitourinary there can be a stress incontinence, there can be a UTIs, there can be hypogonadism, even for that matter infertility and impotence can also occur. So yes, you have to always look at it as a disease and not just as a obesity. What are the treatment goals? The primary goal is to improve the obesity related comorbid conditions, because if you are, अगर आपने comorbidity उसकी सही कर ली, so you have fought 50% with the disease. Now only 50% is left that could be dealt easily. Comorbid conditions को कंट्रोल में लाना बहुत ज़रूरी हो जाता है. So what is the target? The target is weight loss of 8 to 10% over 6 months. Not very fast, it is a very gradual process. You have to consult the patient that yes, it is a gradual process, it will take time, you have to stay with me, you have to uh, you know uh, uh, be as much as motivated as I am to reduce your weight, and many complications will occur along the process. But yes, it's like a yoga, it's like a meditation, so we both have to be in a harmony. So these are the goals. How much diet should be taken? Carbohydrate 40 to 45%, proteins 10 to 35%, and fat 20 to 35%. Now you will say the patient for lifestyle modification. So he will ask you the first question कि should I stop eating? मैं कितना खाऊं एक दिन में? तो you have to calculate the calorie deficit for that patient. So calorie deficit should be 500 to 100 kilocalorie per day as per his normal diet. उससे 500 से 1000 kilocalorie कम कर देने हैं. तो he will ask you the next question, डॉक्टर साहब मुझे तो ये नहीं समझ में आया how it is done. So if he is a male, you have to calculate, you have to make a calorie chart for the person that for the male 1500 to 1800 kilocalorie per day has to be consumed, and for the female 1200 to 1500 kilocalorie per day has to be consumed. Now, the next question he will ask what to include in the diet. Fruits, vegetables, dietary fibers. Reduce the salt intake to less than 2.3 gram percent. Then how much sugars? Should I stop the sugar? No, you don't have to stop the sugar. How much amount is your calories? You have to take less than 10% of that, because some amount of sugar is very necessary for your body. Consume the fat-free or low-fat daily. Total calorie distribution should be in that way. There's one more term that is on a very low calorie diet. It should be given for a short term when our goal is to reduce 13 to 23 kg over 3 to 6 months. So in this, less than 800 kilocalorie per day has to be consumed, out of which 50 to 80 grams should be protein. Okay, for which patient this very low calorie diet is included? For the patients who are poorly controlled diabetes, hypertriglyceridemia, and obstructive sleep apnea is there. So there is a risk of development of gallstones because of rapid weight loss, and prophylactically you can add urodeoxycholic acid 300 mg twice daily. Physical activity, I was talking about it, 150 minutes of moderate exercise per week or 75 minutes of vigorous exercise per week. Pharmacotherapy, people will come to you with XYZ drugs, but you have to tell them that drugs is other, exercises are more important, drugs are secondary. That's why I've kept exercises at first and drugs at second. So whom has to be given? Whose BMI is more than 30 kg per meter square, whose BMI is more than 27 kg per meter square with comorbid conditions. So we have different drugs for different systems which are acting on different systems. On GIT, we have a GLP-1 analog. For the kidneys, we have SGLT2 inhibitors. For intestine, we have orlistat. For liver, again GLP-1 or GIP receptor agonist. And for the brain, we have a lot of drugs: phenetramine, topiramate, lorcaserin, naltrexone, bupropion, GLP-1, myelin, leptin, ghrelin, neuropeptide Y, a melanocyte concentrating 4 receptor antagonist, cannabinoid type 1 antagonist. We will talk of orlistat, which is acting on the intestine. It alters the fat digestion. What it will do, it will inhibit the pancreatic lipase enzyme. So it will inhibit the absorption of 25 to 30% of calories ingested as a fat. Okay, but one side effect, there will be a lot of fat loss in the stools. So your stools will be oily, sticky, there will be a lot of flatulence, and there will be a lot of fat soluble vitamin deficiency as well. uh, Another benefits are there will be a reduction in HbA1c, so control of diabetes, reduction in SBP-DPP, so control of hypertension, improvement in serum lipid profile, so improvement of atherosclerosis. What are the side effects? There will be bulgogamy, there will be abdominal cramps, flatters, fecal incontinence, oily spotting, flatters with discharge, though there is no risk of gallstone. I have told fat soluble vitamins का loss होगा. Okay, and the patient who is on warfarin, the patients who is on warfarin, so vitamin K will be reduced, so you have to increase the dose of vitamin K as well. Next, we have a GLP-1 agonist which are acting on the stomach as well as on the liver. So GLP-1 agonist, glucose dependent insulinotropic peptide is the another name given to it. What it will do, it will inhibit the glucagon release and it will delay the gastric emptying. We have two drugs for it. We have a semaglutide and a liraglutide. Liraglutide is better, but semaglutide is why preferred because it is once weekly subcutaneous dose. It is a chemically modified version of GLP-1, liraglutide. Maximum dose given is 3 mg daily, and daily has to be given subcutaneous, so for the patient it becomes very problematic. So semaglutide is better. Why? Because once weekly dose has to be given and it is long acting. Now, liraglutide initial dose is 0.6 mg subcutaneous once daily. You increase it weekly 1.2, 1.8, 2.4, 3.0, and maximum dose is 3 mg. What are the side effects? Nausea, vomiting, diarrhea. Sometimes constipation is there. Hypoglycemia is there. Increased lipase content, tachycardia, pancreatitis, suicidal thought process is there. Okay. Then we have a semaglutide. उसका dose था 0.6 mg subcutaneous OD. Semaglutide का dose है 0.2 0.25 mg subcutaneous once weekly and increase it every 4 weekly. Okay, only side effect you have to be very careful is about retinopathy. The next drug that we are going to study is a noradrenergic sympathomimetic drugs, but we have to be very careful about the increase in blood pressure, early satiety, drug abuse potential related to it. So we have to be very careful while giving these drugs. Okay, I have simplified in further slides. So phenetramine and topiramate, it is a very sequenced drug, so I've written it in a sequenced manner. You have to start it from 3.75 mg phentermine and 23 mg topiramate once daily for 14 days, then double the dose for the next 12 weeks, and then again increase the dose to 11.25 mg and 69 mg once daily for next 14 days. Okay, what are the side effects? There will be dry mouth, constipation, paresthesia, depression, insomnia, and abuse potential is a lot. Then we have a bupropion and naltrexone. It is a reuptake inhibitor of dopamine and norepinephrine, and naltrexone is a opioid antagonist. Okay, it has to be not to be given in children above. It has to be given only above 18 years of age. It has a lot of abuse potential. They have a lot of dependence, and they have a lot of side effects as well. So let's see the dose and the side effects. Bupropion, naltrexone. Week 1, you have to give 8 mg bupropion and 90 mg of naltrexone once daily for week 1. That is one tablet daily. Then for next week, you will increase the one tablet twice daily. Third week, you will give two tablets in the morning and one tablet in the evening. In the fourth week, you will give two tablets in the morning and two tablets in the evening. Maximum dose is 4 tablets in the whole day. Again, the side effect: constipation, dry mouth, dizziness, insomnia, transient rise in BP. Then we have noradrenergic sympathetic drugs. We have bensphetamine. The dose has to be 25 mg OD to maximum of 50 mg thrice daily. Then we have diethylpropion. The dose is 25 mg thrice daily before meal. Then we have phenetramine 15 mg to 37.5 mg once daily. Then we have phendimetrazine 7.5 to 35 mg thrice daily 1 hour before meal. What are the side effects? It again has a abuse potential, tachycardia, hypertension, dry mouth, and constipation. Then we have a newer drug that is Lorcaserin. Lorcaserin has been disapproved again due to the reason of a colorectal cancer, pancreatic cancer, and the lung cancer. Other drugs we have talked: exenatide, liraglutide, dulaglutide, semaglutide, GLP-1 agonist, or a triple agonist, that is a terzepatide. Okay. Then we have SGLT2 inhibitors, amylin mimetics, leptin analogs like metrileptin. Then we have melanocortin 4 receptor agonist, neuropeptide Y inhibitor, ghrelin vaccining, and antagonist. They are still in the process. So what are the important points? Do not give sympathomimetic drugs if the patient is already hypertensive or he has some coronary artery disease. Okay. So if the desired weight loss is achieved in 3 months, that is 5% weight loss is happening every month, continue the same medication. If 5% weight loss is not happening in 3 months, discontinue the drug and see for the alternative. Okay. Then if there is some cardiovascular disease, never give sympathomimetic drugs. Then you have to give orlistat to that patient. In type 2 diabetic patient, try to give GLP-1 agonist, SGLT2 inhibitors, and metformin. In hypertension, it is recommended, I have already told, because adipocyte के अंदर एंजियोटेंसिनोजन होता है, तो try to give ACE inhibitors, ARBs, calcium channel blockers rather than beta blockers. Angiotensinogen has a directly role in suppressing the obesity. Calcium channel blockers is also important for the treatment of obesity related hypertension, right? Then it is recommended So it is recommended to use a weight neutral antipsychotics. It is recommended to use oral contraceptives over the injectable hormonal contraceptives. It is again recommended to use non-steroidal anti-inflammatory drugs if the patient is coming to you with any problem of osteoarthritis or any pain. So these are the very preventive measures, but small measures which can bring out a big change. Now, the third important thing, surgery, when it is indicated, when the BMI is more than 40 kg per meter square, that is a severe obesity or a moderate obesity with comorbid conditions. Three types of surgeries we have: restrictive, malabsorptive, and the combination of restrictive and malabsorptive both. Now, what are the factors which are causing a visceral fat to get deposited? Okay, these are multiple metabolic factors, adipokine factors, and inflammatory changes. Then we have free fatty acid influx, increased adiponectin. These are the changes that will prevent the obesity from decreased free fatty acid flux, increased adiponectin levels, decreased interleukin 6, TNF alpha, and reduced CRP levels. फर्स्ट सर्जरी दैट इज़ अ रिस्ट्रिक्टिव सर्जरी. हमने रिस्ट्रिक्ट कर दिया है कि अंदर जाए ही ना फूड. जब फूड ही नहीं जाएगा अंदर, कम फूड जाएगा, तो ऑब्वियसली कैलोरीज कम गई हैं तो उसका मेटाबॉलिज्म भी कम होगा एंड इट विल हेल्प द पेशेंट टू लूज वेट faster. It is a laparoscopic adjustable gastric banding. We can see the picture. The gastric banding has been done and that limit the amount of food reaching the stomach and reduces the gastric emptying. We have two procedures. We have a lab band and we have a realized band. These diameters are adjustable and weight loss over the 5 years is 20 to 25%. Then we have a sleeve gastrectomy. We cut along the lesser curvature. Okay, we cut along the lesser curvature and a part of the greater curvature is removed, reducing the surface area of the stomach and leading to excess weight loss, but with many side effects of vitamin malabsorption and other important micronutrients malabsorption. Nowadays, a new study has come, a new procedure has come in which you do not cut, you just sew it. That is known as sleeve gastroplasty. Okay. Next, we have a restrictive and malabsorptive together. Rho and Y gastric bypass, biliopancreatic diversion, biliopancreatic diversion with duodenal switch. It reduces the weight to 30 to 35% over 5 years. Okay, and it also helps in reducing diabetes and hypertension. Then we have an intraluminal gastric balloon. We have put the balloon inside the stomach. If one is a reshaped device, putting two balloons. Then we have an all-weather device, putting a one single balloon, and it has to be kept there for 6 months with BMI of 30 to 40 kg per meter square. Again, side effects of nausea, vomiting, and abdominal pain. Other side effects of bariatric surgery are stromal stenosis, marginal ulcers, micronutrient deficiency, and yes, patient requires a lifelong supplementation of these. Key points: it is a complex metabolic disorder. Only few drugs are approved. Surgery has indicated at only when the BMI is for more than 40 kg per meter square or more than 37.5 kg per meter square with comorbid conditions. So always consult your doctor and get the exact advice so that a proper treatment could be started. If you have any doubt, you can write it down in the comments. You can like, share, and subscribe if you like the video. Thank you.